welcome everyone to the MSRA 2022-2023 Higher Revision webinar. For those that haven't met me before, brief introduction. My name is Muhibbur Rahman. I'm a portfolio GP and a consultant in medical education based here in Birmingham and Solihull. I'm one of the authors for the National Prescribing Safety Assessment, which some of you might have done when you were entering foundation program. I've been an examiner for the GMC, for the PLAB Part 2 OSCE examination, and I continue to examine for Liverpool Medical School for final year and third year OSCEs. I've been teaching about the SJT, both for foundation program and MSRA, and around GP careers now for over 17 years. And our team at eMedic have trained over 61,000 delegates. So, you're in safe hands. So in terms of the format, we're going to start with an overview of the MSRA. The main thing is to get you into exam mode by practicing some high yield exam style questions. So we'll do some clinical questions, we'll do some SJT questions so you can get used to different styles of question. We'll look at revision planning. How can you make the most of your time? How can you succeed to get the best score possible? Please use the chat as you've been doing for comments and discussion, and only the faculty can see those things that you put in there. If you've got a question that you'd like myself or Anna to answer, please ask that in the Q&A, not the chat. And that's because there's a lot of doctors on the webinar. As other people ask things in the chat, they disappear. Whereas if it's in the Q&A, it won't go until one of us deals with it. But if you could leave your questions till the end of the session, where we're going to have a Q&A, that'd be great. Because what we often find is a lot of the questions that you want to ask, if you just wait till I've actually finished the session, they're going to be answered because we already built it into the teaching. Okay. And then when we do the interactive questions, for some of them, I will launch a poll, use the poll to answer the questions. And anyone that wants access to the recording, if you can't stay for the whole thing, for example, please subscribe to our YouTube channel. There was a link in the reminder email, but Anna will also post it into the chat. You can click that and subscribe and opt for notifications so that once we upload the video, you'll be able to get access to it. Okay, so as I would expect, given the timing of this session, most people, about 3/4 of you are planning to sit in round 2. So that's the exam in September, a month away. And then about 1/4 of you sitting it in round 1 2023. So that's the January 2023 exams for August 2023 start. And then a very few people come really early planning for round 2 2023 or later. So let's start with an overview of the MSRA, and then I'll touch on how different specialties use your score, especially some of you are coming for round 1, all specialties that use it recruit in round 1, whereas in this round, there's only a few. And then we'll look at the clinical paper, do some practice questions. We'll look at the professional dilemma paper, do a couple of SJT questions. We'll look at why do people fail or get low scores? Because you can pass, but if you pass with a mediocre score, you may not get an interview, you may not get a job, okay? And how can you avoid those things? And then how to prepare effectively so you get a really good score and you get the job that you want, okay? Then we've got live Q&A, so leave your questions and answers till the end session there. And then finally, we should finish by about 9:15. Okay, so the MSRA, it's an assessment used primarily for recruitment at ST1 and CT1 level for various specialties. Okay, it is used also for ST3 level entry for nuclear medicine, but otherwise it's primarily for ST1 and CT1. And you apply for training via Oriel, which is the specialty recruitment platform for all specialties. So for those of you planning for the next round, the applications close on the 16th of August. And then you'll be invited to book the MSRA if you're longlisted by around the 25th of August. Okay. The actual dates of the MSRA, once you get that invitation to book, you'll be able to log on, create an account on Pearson VUE and pick your own date, anywhere from the 2nd to the 9th of September 2022. We don't know the dates yet for round 1 2023, but it's usually some point in January. Now there's venues available all over the world at Pearson VUE test centers. It's important to note that you cannot just sit this exam as a standalone exam, like you can sit MRCP or PLAB. You can't apply directly for MSRA. You apply for specialty training in one of the specialties that uses it. And then only when you're longlisted, or you meet the eligibility criteria for that specialty, and it's different for different specialties, then you'll be invited to book the exam. You can't just sit it for the sake of it. You have to first submit an application and have that application accepted, and you have to be longlisted. Okay. So the exam itself is 2 hours and 55 minutes, and that's including the 5-minute break that's in between the two papers. The whole thing's done on computer. And the first paper is always the professional dilemma paper. That's 95 minutes. Then there's a 5-minute, and then there's a clinical problem solving paper, which is 75 minutes. Now the timings are separated and enforced. What that means is if you finish this paper with 5 minutes to spare, you'll still only have 75 minutes when you start the clinical paper. You won't get extra 5 minutes. Okay, they're two separate papers that you do back to back with a 5-minute break in between. And there's multiple equated test forms. What does that mean? Well, the person sitting next to you on the same date in the same center may have completely different questions to you, because when you press start, you'll be randomly allocated one of multiple different versions of the exam. That's because the exam's running over a week period, right? If they had the same questions on the second, third, fourth, fifth, sixth, you see, towards the end, some people might feel that there's an unfair advantage, that some people have found out some of the questions from those that sat it early. Okay, so even on the same day, in the same center, you'll have different questions to the person next to you. All right, but all question papers are equated. They have the same proportion of easy, medium, and hard questions, the same proportion of questions in the clinical paper from each subject area, and the same proportion of the different types of SJT questions. So we can compare someone's score on the first day and the last day, but also someone's score who's applying for anesthetics to someone who's applying for GP to someone who's applying for psychiatry in terms of the actual score. Okay, so the different specialties that use it, let's see which specialties people are interested in applying for. If you're applying for more than one, you can select more than one answer. I can see that most people are applying for GP and or psychiatry or child and adolescent mental health. And then quite a few people are thinking about radiology, so then they'll be thinking ahead to the next round. And then a smaller proportion, all of the others, all right? So each specialty used in a different way. So currently in this round, round 2, for GP and psychiatry, 100% of your rank is based on how you score in the MSRA. It's the only thing that will determine if you get a job and where that job is, okay? There's no selection center, no interview, no OSCE, no portfolio at all for GP and psychiatry for this round. We don't know yet, because this was only implemented during the pandemic, because it wasn't possible to have the OSCEs that they used to have for GP and the interviews and portfolio stations that they used to have for psychiatry. We don't know yet what the selection will be like in round 1, 2023, i.e. for August 2023 entry. They haven't published that. That will be published later this year. So it may be that they go back to interviews and OSCEs. It may be that they stick to MSRA only. All we know is what's happening this round. For obstetrics and sexual and reproductive health, the MSRA is 25% of your total score. The rest is made up of portfolio and interview. However, the very top scorers can get a direct offer and skip the interview. They're not recruiting in this round. They'll be recruiting in round 1. For ACCS emergency medicine, 40% of your score is MSRA, but because that's a really competitive specialty, they also use the MSRA to shortlist who's going to get an interview slot. So if you don't score really well, you won't even get an interview. Then even if you've got a brilliant portfolio, you can't get a job. But once you've done well, it carries over and is 40%. The other 60% is about your interview. For neurosurgery and nuclear medicine, it's also 40%. Radiology, it's 33%. But again, radiology uses MSRA to shortlist who's going to get one of the limited number of interview slots. And the competition for radiologists increased hugely in the last few years, such that this last year, you needed a really good score in MSRA to even get an interview slot. For ophthalmology, it's 20%. For anesthetics, it's 15%. But again, only the top scorers get that interview slot. So you need a really high score. Just passing isn't enough. You won't get an interview. So therefore, you won't get a job. Pediatrics are not using MSRA this year. They used it last year, but they're not using it this year. Okay, so let's make a start and look at some questions for the clinical problem-solving paper. So this is a 75-minute paper, in which case, within which there are 97 questions, but only 86 carry marks. That's because in every paper, there are 11 pilot questions. They're for research purposes. They aren't identified in any way. They won't look any different. They won't have a little asterisk. You have to take all 97 seriously, but 11 of the questions carry 0 marks. There are 2 predominant formats: extended matching questions, which come in sets, and single best answer questions. Within that, some questions, there might be an algorithm. There might be like a diagram from a nice guideline, and you drag the correct answer into the right slot. Some might have a picture, although there have been very few of those in the last couple of years. And you might get 1 or 2 multiple best answers where there's more than 1 correct answer. Last year, there weren't any, but there have been in some previous years. So predominantly, you're either going to get extended matching questions or single best answer questions. So I'll show you what they look like in a minute. But in terms of the level and the topics covered, the level of knowledge being tested is the level of knowledge expected of a doctor who's in F2, i.e. You've already been qualified as a doctor. You've finished F1. You've been seeing patients and doing things. So it's at a higher level than finals, but it's not at the level of membership. Now, don't underestimate the exam, because it's a really challenging exam because of the fact that it's not about the depth, it's the breadth. They expect you to know a little bit about everything. These are all the subjects covered in the clinical paper. And the questions will be in about equal proportion of these 12 blocks, i.e. there'll be about as many cardiovascular questions as dermatology, ENT, and eyes combined. There'll be about as many pediatrics questions as infectious disease, hematology, immunology, allergies, and genetics combined. So you can see, you want to allow enough time to prepare such that you've touched on all of these curriculum areas, okay? So EMQs come in sets of 2, 3, 4, or 5, okay? On any given screen, there's only one question. And what happens is, let's say there's a set of 3. All 3, the answer options will be the same, but just the question will change on each screen. I'll show you what it looks like in a minute, okay? And because you've got 97 questions, you've got 75 minutes, you've got about 45 seconds per question. That's one of the other challenges, is time, okay? So what we'll do, let's do some sample questions. I'll show you a question. You'll have about 45 seconds, and then I'll launch a poll, and then we'll see how we get on, okay? So here's the first question. Okay, what we're going to do is I'm going to show you the next 2 in this set. Can you see? EMQs come in sets. So in this case, this is every question has a title. This is about management of hypertension, 1 of 3. I'm going to show you 2 of 3, 3 of 3. Write down your answer at home, and then we'll go through all 3 and I'll launch polls for them. It's just if I give you the poll now and do the teaching and explain the answer for 1, it might give away the answer for 2 and 3, which you're not going to have in the exam, right? So let's look at question number 2. Okay, we're going to move on to the last one. Okay, great. So we're going to move on to look at the answers now. Okay, use the poll. So you've already selected your answers. I'm just going to launch the poll for each one to see what people thought. So here's the first one. Okay, great. So the main split, 70% of you picked A, ACE inhibitor, about 20% of you picked C, calcium channel blocker, and then very few picked any of the other options. So key things here is this patient's 45 and his ethnicity is Asian Bangladeshi, okay, and is otherwise fit and well. So and he needs drug treatment. So what drug are we going to give in the first step? Correct answer is A, an ACE inhibitor. Okay. And that's because this patient's not diabetic. He's not Afro-Caribbean. So what matters is the age. Age under 55 is an ACE inhibitor first line. Okay. So this is the NICE guideline 2019. If your patient is not diabetic and they're not Afro-Caribbean, then you look at the age. Age under 55, first line would be an A-class drug, which means ACE inhibitor first line, ARB if there's a reason why they can't have an ACE inhibitor. Okay. Whereas if it was 55 plus, it'd be calcium channel blocker first line. If they were Afro-Caribbean, it'd be calcium channel blocker first line. Okay. If they were diabetic, then any age, it's A-class drug first line. All right. So let's look at the second one. So key things here is that this patient's stage 2 hypertension, so that means they definitely need medication. Okay. And they're Caucasian and they're 54. All right. So what's the first line? Correct answer is the same. ACE inhibitor. Now, this is what I call the EMQ trap. Be honest, let me know in the chat, how many of you thought, you know what, I know this one, you've just heard me talk about it, but then thought, you know what, I've just put A for the first one. They wouldn't put two A's in a row, and you changed it from A to either B or C. Be honest, let me know in the chat. Did anyone do that? Usually there's at least a few people that have done that. See, each question is separate in an EMQ. And so sometimes all of them in the set will have the same answer. If that's what fits, select the answer that fits the scenario rather than looking for patterns or conspiracies, because there aren't any, okay? So it's really important that you select what fits. Do you see? Again, same guideline, right? Look, patient wasn't diabetic. They weren't Afro-Caribbean, so we look at age. His age was under 55, so you start on A, and so ACE inhibitor would be first line. Okay, last one in the set. This is the harder one. You often see this in the exam, that in a set of 3 questions, the third one's often the hardest one. Okay, great. So now the big split is between ACE inhibitor and calcium channel blocker. Okay, most people picked ACE inhibitor again. Then over 40% picked calcium channel blocker. And then the smallest one, less than 10%, picked B, ARB. So key things here is this patient's diabetic, but is also Nigerian. Okay. So the correct answer here is B, ARB. So less than 10% of you got this one right. It's the hardest one in the set, so don't worry. That's one of the reasons you're here, right, is to understand the guideline. So it's a good example. It's a common topic. It's an important topic, right, hypertension. So why is that the case? Well, it's understanding the guideline. So if the patient is diabetic, regardless of age, you're going to start on the A side. Now, for most patients, A means ACE inhibitor, first line. Okay, they'd only have an ARB if they can't tolerate it. However, this patient was Nigerian, so of Afro-Caribbean heritage. In the new guideline, patients who are Afro-Caribbean, whenever they need an A-class drug, whether that's here, or here, you go straight to ARB rather than ACE inhibitor, because the evidence is that it's more effective. And so because they're diabetic, we're going to start here, but because they're Afro-Caribbean, that A isn't ACE inhibitor, it's ARB, okay? That's why it's B, angiotensin 2 receptor antagonist, ARB, okay? So, it's a high challenge question. Right, let's do another set of just 2 EMQs, then we'll do a couple of single best answers. So again, I'll show you both questions, write down your answers, 45 seconds for each one, and then we will go through the answers and explanations. Here we go. Okay, moving on to the second one in the set. Okay, that's time. So let's go through and look at the answers. So let's use the poll. Okay. Now, before we look at the answer to this question, this is an example of a two-step question. All right. The question's asking about a test, an investigation, which is the second step. The first step is looking at this scenario, working out what is the likely diagnosis, what is it that you're trying to exclude or include. Okay, so type that into the chat. What is it that, based on this scenario, we're trying to diagnose? When we say most appropriate diagnostic test, for what? What is it that we're looking for? You see, in a two-step question, the first step's always very straightforward. They're not trying to trick you or catch you out because that would make it unfair. It's got to be fairly straightforward. Essentially, what we're looking for is this a UTI or not? That's what we're trying to diagnose, right? Because you've got dysuria, nocturia, urinary frequency. It's a female patient, okay? She doesn't feel thirsty. I.e., we're not thinking about, could this be diabetes? Because if she felt thirsty, maybe we'll be thinking about diabetes, especially if there's a history for months, right? We're trying to decide, is this a UTI or not? And something really important is the most appropriate diagnostic test, okay? And it's a good example of, to do well in the exam, you both need a good knowledge base, i.e., you've put the hours in, revise the subjects, but then you also need good exam technique to read carefully, pick up small things and pick up keywords that will help you decide what is the examiner asking. In this case, we're looking at this word here, the most appropriate diagnostic test for a UTI, okay? So the correct answer is B, urine culture and sensitivity. And well done, about 2/3 of you got that right. That's really good. A lot of you picked urine dipstick. That's not an appropriate diagnostic test for this lady because she's 70, okay? So if we look at the guideline, for a suspected UTI, in a woman under 65, no risk factors for complicated UTI, you could use a urine dipstick. And if you had both leukocytes and nitrites, because there's a more than 90% chance that they've got it, you don't even need to send a culture. You could just treat that. So you could diagnose just based on the symptoms and the dipstick. But women 65 plus, women with a catheter, women at risk for complicated UTI, urine dipstick's not reliable. You can't use that for diagnosis. You need a urine culture. Other patients where you'd want to send a culture, patients who are pregnant, someone with a persistent UTI, a recurrent UTI, someone who's not resolving with treatment when you just used empirical antibiotics, because it could be that they have resistance to whatever antibiotics you're given. And you see, just picking up the fact that she's 70 and that we're looking for a diagnostic test rather than a screening test is why the right answer is B and not A. You see, you need both the knowledge of the guideline, but you also need to have picked up that small keyword, okay? Right, second one in the set. Okay, great. So big spread of answers here between A all the way down to E. So the three popular answers are B, C, and E. So urine culture, a KUB X-ray, and a DMSA scan. These are the three really popular ones. So correct answer here is E, DMSA scan. So well done. About just over 1/3 of you got that right, okay? A couple of things that are really important here. Age of the child, that they've had multiple UTIs, and that the last episode ended 4 months ago. So what does most appropriate mean? That keyword means most appropriate for this patient who's 4 years, had multiple UTIs, the last one 4 months ago, in this situation, okay? So DMSA stands for demercaptosuccinic acid, okay? So UTI in children 3+, if they've got an atypical UTI, you'll do an ultrasound during the acute infection. If they've got recurrent UTI, which was this patient, they'd have an ultrasound within 6 weeks, but then the DMSA scan 4 to 6 months after the acute infection. Do you see? It's 4 months after the last episode. So they would have already had an ultrasound scan earlier. At this stage, what we're looking for is a DMSA scan, okay? So let's look at some single best answers. Single best answers also have a title, but there's a question and then a list of options. Commonly 5, but there can be 6 or 7 options, okay? Let's have a look at this question. Okay. I'll stop there. So a really big spread here. Actually, all 5 options have been picked by lots of people. The 2 most popular are C, dexamethasone, and E, haloperidol, both about equally even. Okay. So key things are that we're looking at which of these would be least helpful. Now, this is an example of what we call a negatively framed questions. The majority of questions in the MSRA clinical paper will be positively framed, i.e. they'd ask, what's a likely diagnosis? What would be a useful test? What would be a useful investigation? But you'll get some questions which are not asking what you should do or what would be helpful. They're asking what wouldn't be. So this question is asking which would be least helpful. That's an important part of technique, reading the question carefully, because if you miss that, it's not asking what would be helpful, what would be the most useful, but the least helpful. You could easily have the knowledge and still lose the mark because of poor exam technique, because you either misread, missed, or misunderstood. What is the examiner asking? So you can see the symptoms they've got are severe nausea and vomiting. Okay. So the least helpful would be hyoscine hydrobromide. This is used for respiratory secretions and bowel colic in palliative care. Okay. Whereas all of the others, this one, depending on the patient, they can be very useful as part of managing palliative nausea and vomiting. Okay. So again, let me know in the chat, is there anyone that actually just missed the fact it said least helpful and thought, okay, you know what? I've seen patients who've got brain mets, for example, and dexamethasone is quite helpful for that. Or I've seen patients where they use haloperidol IV or in a syringe driver, and that can be quite useful to calm their nausea and vomiting in a palliative setting. Or, cyclizine, lots of people use for nausea and vomiting. Or, this in a syringe driver goes quite well with certain other drugs. Again, is anyone that did that? Yeah, absolutely. Okay. Don't worry that you've done it here. Hopefully you won't do it in the exam. That's why we're here, right? Okay. That you can have the knowledge and still miss it, the mark, because you either misread or misunderstood the actual question. The question is asking which would be least helpful. It's not that this isn't helpful in some patients in palliative care for his symptoms, which are severe nausea and vomiting. That's not what this is used for. It's for drying up respiratory secretions and for dealing with bowel colic. Okay. Last one in the set. Infectious disease. So key thing here, what do you think is going on here? That's what the question is asking, right? Okay. A couple of really important things. They've got Lyme disease. What do we use to treat Lyme disease? What's first line? Doxycycline. Okay, yeah, great. And bit of a tachycardia. Blood pressure's dropped a little bit. Facial flushing. So the correct answer is D, the Jarisch-Herxheimer reaction. Okay. And well done, actually, about half of you got that right. It's a hard question. All right. This isn't what you'd expect to see in an anaphylactic reaction. All right. In what most patients think has happened is that they're having a reaction to the drug and they want to stop. But if you understand, because it's so common with this, one of the things you should counsel patients when you give them doxycycline for Lyme disease is that this can happen and that they should keep going. It's actually a sign that it's working. Okay. So it can actually happen with any antibiotic treatment, but it's really, really common with patients who are given doxycycline for treatment of Lyme disease, about 15% of them. And then what else? What other infections this reaction commonly seen? Type into the chat. And what you see is typically within a day of starting treatment, because it's actually working, it's killing the bacteria. The death of those bacteria release toxins, which cause the symptoms. So they get fever, getting worse. They often already had a fever, right? They'll get chills, muscle pains, headache. But then some of the key things that you're looking for, tachycardia, hyperventilation, they get flushing because of vasodilation, and then just a very mild hypotension, okay? So yeah, the other common thing that you'll see is encephalitis, okay? And also in leptospirosis, okay? And, when people have antibiotic treatment for these things. Right, so in terms of clinical, how do you prepare effectively? You want to do a mixture of reading and practicing questions, okay? So passive learning is reading as an example, okay? If you read, then make your own concise notes. You make that reading more active. So when you do active learning, a good example of that is practicing questions like we've done now, or using a question bank to practice questions. And that way, it sticks into your head longer. And you want to cover the curriculum systematically. You want to practice realistic questions, you want to work on exam technique, and you want to do some timed mock exams so you get used to the time pressure. It's one of the big challenges. 97 questions in 75 minutes is tough, okay? And it's also understanding what the questions are going to be about in the exam. So the questions are going to relate to one or more of these 5 things. So investigations, diagnosis, emergency care, prescribing, but also management that's not to do with prescribing. Knowing who to refer, who to admit, who to send back to the GP, who, if you're in the GP setting, to refer into hospital, and so on, okay? And then mapped to those 12 curriculum areas that we looked at earlier. So things that you can find helpful if you want to do some reading. The Oxford Handbook of Clinical Specialties covers a lot of those other specialties that make up, things like the allergy, the immunology, the psychiatry, the ENT, ophthalmology. And then the Oxford Handbook of Clinical Medicine covers a lot of the more broadly medical topics like the cardiovascular, the respiratory, the endocrine, those things. Probably worth spending one day on the BNF, just reading the section at the beginning, which covers prescribing in palliative care, pain management, and general principles of prescribing. And then the first page of each chapter covers like a treatment summary of important drug classes affecting that system. That can be useful as a primer for pharmacology, okay, which is one of the headings, right? And then if you want to read, because even these, the latest editions, they're already a little bit out of date. A lot of guidelines have changed since then. So if you want to read a lot of guidelines quickly, what you might find helpful are clinical case cards. So we publish these twice a year. The latest edition was published July 2022. So they're bang up to date. Okay. So 112 topic reviews is 56 double-sided cards, and they're mapped to the same things that your questions are mapped to in the exam. Okay. So, for example, we've got the current guidelines for impetigo, which includes for low risk, non-bullous, that actually, if it's localized, you can use hydrogen peroxide. Notifiable disease, updated to include SARS-CoV-2 and COVID-19. They were only added, in recent times, okay? The new acne guidelines, which again, very recent changes, all right? And so there's a printed version. So they're printed cards, you can carry them around. And there's also a digital version. So especially if you're sitting the September exam and you're outside the UK, by the time a printed one would arrive, you would have very little time to use them. So the digital one is instant access, okay? And I'll just show you, if you actually go to our website, and in the MSRA section, we've got various other things for questions and so on. But if you just go to emedica.co.uk/case cards. If you want the printed ones in the UK without access to the digital ones, you can just click buy now here. If you click subscribe, there's an option of either the digital ones or in the UK, the bundle where you get the printed ones posted to you and access to the digital ones straight away for a year. If you're outside the UK, I'd recommend the digital ones. You get access straight away. You don't have to worry about waiting for it to arrive, especially if your exam's in September, okay? And I will post this link or post the link to the case cards into the chat. And then, as I said, the mainstay should be practicing questions. So there's lots of question banks out there. When we first started teaching this 15 plus years ago, there were no question banks. We developed the first ever question bank for what was the precursor of the MSRA, which was called the GP Stage 2 exam, okay? So ours, I'll just show you, is mapped to the curriculum. There's a study guide which you can download. There's a section for clinical questions, which are mapped to the same headings: cardiovascular, respiratory, gastro, ENT, and so on, okay? And then when you do a set of questions, ENT, okay, if you get it right, this is probably enough, a concise explanation, okay? If you get it right, read that. If you get it wrong, what you might do is, as well as reading this, you might then read up a little bit in the Oxford Handbook. And you see our EMQs are in exactly the same format, one of three, only one question on the screen, as in the real exam, rather than all of them on the same page, okay? And then I'll show you the SJTs later, but there's also some timed mini mocks and 3 full timed clinical mock exams. And you can do those, either in timed conditions or in untimed conditions if you just want to do them one at a time, okay? So there's over 2,100 questions. There's 1,900 plus clinical questions, over 200 SJTs. It'll take you about 100 hours of learning to cover all the questions and read the explanations and do the mocks and read the study guide, okay? And you can subscribe anywhere from 1 month all the way up to 12 months. And again, Anna will post a link to where you can subscribe to that. Okay, so we're going to move on now and do some questions for the professional dilemma paper. And then we'll look at how to prepare, for this paper. We'll take questions and we'll finish up. So this one in the real exam will come first. It's 95 minutes. One of the big challenges for this, even more so than the clinical, which is tight for time, is timing. So you're going to have 50 questions in 95 minutes. Only 42 are marked. 8 pilot questions carry 0 marks. You don't know which ones. So timing, really important. The way the SJTs are marked, if your answer isn't perfectly correct, you can still get partial marks. Whereas clinical, you get it right, you get a mark. You get it wrong, you get nothing. Okay? But the SJT, you get it wrong, depending how close your answer is to the best response. Sometimes you can be wrong and still get 90% of the marks in section 1. Now, there's 2 sections within this, and about half the questions are in section 1, half are in section 2. But section 1 carries the bulk of the marks. So section 1 of the SJT paper are ranking questions. You get a scenario, there's 5 options, you rank them best to worst. In a few questions, there'll be 4 options, you rank them best to worst. Section 2, there's 8 options, you select 3 that go together to make one correct response to the scenario, okay? So section 1 questions are worth up to 20 marks, section 2 are worth maximum 12. That's why section 1's worth more, even though about equal number of questions. So the reason the SJT has been used and continues to be used is that it's been used for a long time outside of medicine. And it's been validated that it can be a way to test if someone's suitable for a job if you map it to the right competencies, okay? Unlike essay questions, which they used to use before as part of the recruitment process and application, it's objective rather than subjective, and most importantly, it's machine markup. In fact, it's marked by computer. So what it will do is you don't need any clinical knowledge for the SJT. What really helps, though, is being familiar with the NHS and how it works, and having a good working knowledge of GMC, ethical guidance, and good medical practice. It will give you a work-based scenario where you have to make a difficult decision or use your judgment. And some of them will involve ethical or professional dilemmas. And they're going to test you against 3 competencies in the National Person Specification, which are empathy and sensitivity, professional integrity, and coping with pressure, i.e., do you show positives or negatives for these in the way that you approach your answer? And for some questions, knowledge of core GMC guidance can be really helpful. So 2 sections, the approach, the way they're marked, the way they look, completely different. Section 1 are ranking questions. Section 2 are selection or multiple choice questions. So section 1, you get a scenario. There'll be either 5 options or 4 options. So if there's 5 options, 1 is the best or most effective option. 5 is the worst or least effective option, okay? If there's only 4, 4 is the worst or least effective. You've got about 1:53 for each scenario to read it, think about it, and do your ranking, which in itself takes some time. I'll show you how that works in a minute, but let's have a look at a first question. Here we go. Okay, that's a minute 50 now. Okay, by this time you want to make your decision because it's going to take you 5 seconds to actually move things around. Okay, so write down now in the chat your response, i.e., what order would you do these? So remember, whatever you put first is the most appropriate. Whatever you put last is the least appropriate. So just write your full order into the chat. I just want to see what kinds of things people thought. Okay, so we've got popular options are EDBCA or DEBCA, or a few people with DEABC, okay? So a lot of people started with D as number one, and a lot of people started with E as number one. And then we've got some people who started with A as number one. Okay, they thought they're best. So let's do a read through. And what I recommend you do in the exam is you don't have time to come back to any of these. You want to read it carefully, think about it, give it your best shot, be strict to time. Don't spend too long on any one question. You want to finish the last question with a few seconds to go. Okay, because with an SJT, if you come back to a question, you end up having to read the whole scenario again anyway. It's not like a clinical where you can flag it for review. So if there was a couple where you just narrowed it down to the last one, you weren't sure and you guessed, you could flag it for review and you could come back to it and maybe have another look if you've got a few minutes left at the end. Okay, so one thing to do is as you're reading, try to picture the scene and read carefully and think, why have they said that word? And what could that mean? Then for each of the options, think about the potential outcomes and the potential for good and the potential for harm. Okay, so you're just finishing a busy shift and it's a night shift and you're exhausted. Any night shift you'd be tired, but there's some where it's exhausted, right? Generally you can't sleep. Now the morning on-call doctor's called in sick, and just as you're leaving, the nurse says, look, medical staffing want you to stay on until the early afternoon. They found a locum, but they're not going to be able to get there till the early afternoon. I can see if it's morning and it's early afternoon, it's a few hours that they want to stay on. But this bit's really important at the end. You're barely able to keep your eyes open and unable to concentrate. There's tired, there's exhaustion. There's, when you're trying to, you nod off. First question before we look at the actual correct response. Is it safe for a doctor in this situation to be seeing patients and assessing patients? Is that a safe situation? Absolutely not. Right, okay, good. Okay, so now before I go through the best response, well, actually, let me show you the best response and then I'll explain how it's marked and then I'll ask the question. So the best response is DAEBC. DAEBC. Okay. I'll come back and explain why that's the best order in a second. Okay. But first, quite a few of you had these two the other way around. You had A first and D second. So of those of you that put A first and D second, why did you put A first and D second? Just share in the chat. What's your reasoning? What's your thinking around putting A as the best option? Okay, great. So various people saying things like the rota coordinator is the one that asked, communicating clearly that so that they can get on with finding someone else before escalating. So let me make it absolutely clear if a few others are thinking something along these lines. Was anyone thinking along the lines of, okay, they've asked me, if I say no, they can get on with trying to ask someone else, because contacting my clinical supervisor and discussing the situation, the whole thing, explaining all of that's going to take a long time. So I do this first and then I do this. Is there anyone that was thinking along those lines? I.e., you're thinking about this as, this is the sequence of time I would like to do this. I'd like to do this first, and then I'd like to do this. And then you were thinking about the order you would do it in time rather than what is the best thing if it was the only thing you're going to do. Yeah, a lot of you. This is the most common mistake that leads people to lose marks in section 1. So don't worry that you've made it. Again, that's why you're here, right? It's the most common mistake. Section 1, ranking, the key word in your mind should be or. When they're asking you to rank, each of these is completely separate, a discrete action. You have to imagine, if you could only do one of them, and this is all you're going to do, and you're not going to do anything else, which one is the best one, the most appropriate? Is it A or B or C or D or E, not which order of time would you do these things in? I do this. You're not doing all of them. You're only going to do one, which is the most complete response, which is the one that most appropriately maps and shows most positives for these three domains: empathy and sensitivity, professional integrity, coping with pressure. And that's why, if you're only going to do one of them, the best option is D. Okay? Because if you discuss the situation, so first of all, there are legal limits to how long you can work at night or in one continuous go, including shifts overnight, before having compensatory rest. And that's because research shows that a really exhausted doctor, their judgment is affected similarly to someone who's drunk several times over the legal limit of alcohol, i.e. it's unsafe. On top of that, look at the scenario. You're barely able to keep your eyes open and unable to concentrate, i.e. it's clearly unsafe, okay? And so they shouldn't be asking you. Now, if you say no, they're just going to ask someone else. Whereas, you can see, if you explain the whole situation to your consultant and explain that, look, I don't think this is safe, but also they're asking me to do this and I don't think it's safe. There's someone with more authority to challenge medical staff. You shouldn't be asking my juniors to stay on when they've just finished a night shift. This goes against, safe working, okay? This is inappropriate, because you can say no, but you might feel it difficult for you to change the system. So what this does is it both thinks about your safety, you know your limits, that's part of coping with pressure, but it also deals with that if you see something inappropriate, they've asked you to stay on, you're challenging that. If you're only going to do one thing, this is the most complete response. It shows positives for multiple of the options. Now, if that wasn't an option and you could only do one of these, which is the best one? Hey, because if you refuse, you're recognizing it's safe for you. It's not safe for you to keep seeing patients. So you're doing the safe thing. You're recognizing your limits. That's part of coping with pressure. It's one of the subdomains of coping with pressure. Each of those three is broken down into lots of subdomains, okay? And for a particularly hard question, for most questions, I recommend you start at the best and you work your way down to the worst. But like, this is a really hard question. For a particularly hard question, often, if you find the best two, find the worst two, the middle will find itself. So let's leave E for a minute. Let's look at B and C. Do you all agree that it's not safe for you to stay on and see patients? Everyone said that that's not safe, okay? So what separates B and C? Because in both of these, you're doing something dangerous. You're staying on even though it's not safe. What separates B and C is that in C, your reasoning is more about you than B. Like they're both bad, but B is slightly less bad. I can see in B, you're doing something unsafe. So you're not recognizing your limits. And you're explaining you can't stay until the afternoon, but you'll do a few hours, okay? So, you're giving them some help, okay? But not recognizing that it's unsafe for you to do that. Whereas in C, what you're saying is, look, I'll do a few hours, but I want you to give me like 8 hours, a full day back. You're trying to take advantage of an emergency situation, which guidance says that you shouldn't do. Whereas, if they ask you to do a locum in advance, someone's booked some leave, would like you to cover an extra session, in 2 weeks' time, it's perfectly reasonable for you to ask for locum rates, something extra, right? But in an emergency situation, you shouldn't try to take advantage. Do you see? So in C, you're trying to take advantage. That's why it's slightly worse. Now, this is a good example of sometimes what you pick is what, in optimum situations, a good doctor should do. In real life, you're really tired, you don't want to do it. You might want locum rates, but that doesn't mean that that's what the right answer is according to the SJT. Okay, now we're left with E. Now, some of you put E actually much higher, either second or even first. What's the problem with E? Why is E here? Why is it not as bad as B or C, but why is it worse than D or A? What's the problem with E? Well, the problem with E is twofold. So one is, coming back early evening prior to your night shift, they don't need you. The locum will have arrived by the afternoon, okay? So it seems helpful, but it's not. They don't need you, okay? But the second thing is more subtle. Anyone know? This is why there is some risk associated with E, why it's worse than DNA. It's the fact that if you're coming back before your night shift, at the tail end of your night shift, you will have gone over hours, maybe overtired, and start making mistakes. You're not thinking about the whole period. Do you see? So there is an element of risk involved here. It's not as risky as seeing patients when you absolutely can't concentrate, okay? Because it might be that the next shift isn't quite as busy. You don't know, okay? And so, do you see? Key things. you think about this, or this, or this, or this, or this. If it's the only thing you're going to do, they're separate options. The key word is or, not and not then, not this, then this, then this. It's not an order of time, okay? And it's about better or worse. You've got to compare it to the one above and the one below. When mapped to those domains, which one shows positives and negatives for those three domains, okay? That's really, really important. Okay, so section 1 is really complex how it's marked. It's marked using keyed response marking. So if there are 5 options, you get 20 marks if you get it fully right. So you had D, A, E, B, C, you get 20 out of 20. What if you had 3 right and 2 wrong? How many marks would you get? The answer is it depends. It depends which 3 were right and which 2 were wrong. It's not that you just get 60%. If, for example, you had these 2 swapped around, overall, that's still a sensible approach. You'd actually get 18 out of 20. That's 90% of the marks. Whereas if you had D at the bottom and C at the top, you've still got 3 right and 2 wrong, you'd get a much lower mark. It's called keyed response because every possible combination has a number of marks keyed to it. Okay? That's why it has to be marked by computer. There is only ever one option that will give you the full marks, but if it's incorrect, as long as you have ranked everything, you'll get somewhere between 8 and 18 marks, even if it's wrong. Even the worst option will give you 8 marks, okay? So just remember, each option is discrete. It's or not then, and you need to compare it to the one above and the one below, okay? Now, I'm going to show you how you will actually do that in the exam by showing you our SJT questions, okay? So how it will work in the actual exam for ranking questions, it will be like this. So you'll have your scenario here. In this case, there's 4, okay? Sometimes there'll be 4, mostly there'll be 5. You've got 1, 2, 3, 4, and you've got your options here. And what you'll do is you'll actually move them. So you can see, I'll put this one first, this one second, this one's third, this one's fourth, okay? And then, like this one, you can see it's 10 out of 16 because only 4 is out of 16, okay? If I jump to one that's out of 5, like this, okay? You can see, again, it will mark it. You move things along. This is how you actually do it in the exam. You drag things across, okay? And then this marks, there was no commercially available software that could have both this drag and drop function, just like in the real exam, and mark in the same way. We had to get a programmer and invent our own software so it marks exactly the same way as a real exam, okay? So that's how it will be in the exam. Do you see how it takes a bit of time to actually drag things across? That's why you want to make your decision no later than about 1:50. So you've got a few seconds to actually drag things across because that takes a bit of time. Do you see? Okay. So that's section 1. Section 2 is much quicker to select, but they carry less marks. So I'll show you section 2 in a minute. So section 2, you get a scenario like section 1, but it takes longer to read because there'll be 8 options, not 4 or 5. And you're picking 3 that taken together make the most appropriate combined response. So let's do a section 2 question. Here we go. Okay, I've launched the poll. Time's up. If you select your options, so select your 3, please. Okay, and I'll stop you there. Great. So the popular answers are B, D, E, G, and H. These are the ones that are popular. Okay. So again, read the scenario, picture the scene. You've got this patient who's diabetic. He's on the care of the elderly ward, having had a fall. Can see we can logically deduce from that it's bad enough that he needs to be admitted to hospital. Okay. And you notice an unexplained spike in his blood sugar levels each evening before dinner. And, you know, he's mentioned he's got a sweet tooth. You've seen his wife who comes every afternoon, giving him some sweet as a treat. Okay, so you're thinking about the 3 most appropriate actions to take. So the correct response is B, G, and H. B, G, and H. Now, lots of you had G. Nearly all of you had G as one of your options. Quite a few of you had H, but only just over a third of you had B. Instead, a lot of you had either D or E as your third option. So the way that these are marked in section 2, you basically get 4 marks for each bit. So like if you had all 3 of these, you get 12. So maximum 12 marks for a section 2 question. You had 2 right and 1 wrong, you get 8. You had 1 right and 2 wrong, you get 4. You had none of these options, you get no marks at all. Okay. So why is that? Let's look at it. Let's look at it. So just go over the marking first and I'll go over it. So maximum 12 marks, 4 marks for each bit that's right. There's no negative marking. Key thing, remember, it's the most appropriate combined response. Add in the word and ask yourself, does it make sense together? Okay, so look, we'll go back here. Section 1 is not about good or bad. It's better or worse. It's comparative. Section 2, there'll be there's something clearly wrong. It goes against the GMC guidance, shows a clear negative for one of the 3 domains. So you could actually, in your mind, cross it out. So for example, option A, we can immediately cross off. Why? What's wrong with option A? Why could you immediately remove that it can't be part of the right answer? The word confront. Okay. This is a patient. He's in hospital. He's your patient. Is it appropriate to confront someone? No, you might discuss with something, okay? You might, approach, you might have a chat about, but to confront a patient is inappropriate. It's a negative for empathy and sensitivity. How do you think they're going to feel? Especially it's about someone else's behavior. He can't control his wife's behavior necessarily, okay? And so A is out because it shows a negative for empathy and sensitivity, one of the 3 domains, okay? Option C isn't in the patient's best interest. If it's unexplained spike, if you measure it less frequently, it might be that it continues to get even worse and it just takes you longer to pick it up. It's not like, oh, if I can't see you, it's not there. You know, we're not 3 years old, okay, playing hide and seek. Option F, this got negatives for lots of things. So first of all, understanding your role, okay? It's not your role to decide how often someone can visit. Who decides that? The senior nurse on the ward matron, or the ward manager. They're the one decides, okay? Sometimes if it clinically becomes an impediment to someone's care, a consultant might suggest that someone doesn't visit as much, but it's not your role as an F2. That's really important. In every scenario in the MSRA, you have to place yourself at the level of an F2, okay? A junior doctor. So it's not your role. It's understanding your limits. But on top of that, can you see, think about a patient's overall well-being. This patient's in hospital. They might really enjoy, they might really like, for their mental well-being, it might be really nice to have their wife come and visit them every day. It's not for you to decide that. So again, think about empathy and sensitivity. Think about the holistic approach, okay? So that's why F's out. So that leaves D and E. You see, in section 2, sometimes you can get rid of options because there's something wrong with them. Sometimes you're only left with good options, okay? Option D and E, the same thing that's wrong about D is what's wrong with E. What is it? Anybody? Both D and E would constitute an inappropriate breach in confidentiality. Look, his wife is already visiting to discuss his recent results. Doesn't mention in any of the options here, get his consent to discuss or share information. Just because someone's married to someone doesn't give them any automatic right to confidential information. Similarly, you can see if you discuss his results with his wife, that's confidential information. Doesn't mention any of the other options that you've got his permission to do that. Both of these would be an inappropriate breach in confidentiality. And it's a good example of knowing GMC guidance on confidentiality, which covers when you can and can't do that. And someone's asked, even if they're the next of kin, doesn't give any automatic right in the UK. And that's different in some countries. And it might be that some of you, where you're practicing, if you haven't spent time in the NHS and aren't familiar with this guide, it might be that because there are some countries where next of kin automatically get certain rights, not in the UK. Okay. Now, how do you know you've got it right in section 2? You know you've got it right by reading back all of your options and trying to picture it together as one story. When you add in the word and, does it make sense? If it doesn't, you need to change something. If it does, you've probably got it right. It's not necessarily alphabetical order. So look, picture this. This is the scene. Does this make sense? Okay. The first one I do is this. Mr. Jackson, discuss, not confront, discuss. Mr. Jackson, your recent blood sugar levels have been all a little bit high in the evening before dinner. And so it'd be quite useful to see why that could be. Can we just talk a little bit about your diet? Let's go through yesterday as an example. What did you have for breakfast? What did you have for lunch? What did you have for dinner? Did you have any snacks? Did you have anything else in between? Okay. And, suggest some sugar-free treats like Mr. Jackson. Well, look, as you've got a sweet tooth, these are some kinds of things that might give you that, I've got that craving for something sweet, but because they actually haven't got sugar, they shouldn't affect your blood sugar in the same way. And continue to monitor his blood sugar levels at least daily. Does that make sense together? Absolutely. Does it deal with the situation as best as you can as a combination? Yes. That's how you know you've got it right and you're going to get full marks. Okay. So section 2, make sure, remember, it's the most appropriate combined response. Add in the word and in between. Does it make sense together? If it doesn't, change something. So how to prepare? First thing is you need to know the subdomains within each of those domains and what would be positive and negatives for them. You need to have a good understanding of good medical practice and the other core GMC ethical guidance. You need to understand the difference in approach, mindset, and marking for section 1 and section 2, and practice realistic questions to time. So the ethical guidance that you want to learn about, the biomedical ethical principles, autonomy, beneficence, non-maleficence, justice, and how to apply them, confidentiality, when you can and can't breach it, capacity, advanced refusals, DNARs, Gillick competence, the Fraser guidelines, consent, Bolam, Montgomery, what's replaced that, the new GMC 2020 guidance, for example, personal beliefs in medical practice and how it applies to doctors and patients, financial issues, raising concerns about other things you've seen, safeguarding both adults and children. And so, in terms of how to prepare, you could also use our practice questions for, we've got lots of SJT questions as well, both section 1 and section 2. And section 2, the way that works in the exam is like this. You've got a scenario, there's the 8 options, and you just tick them. You're not picking which one's first, second, third, you just tick them. And then, that's how it'll work in the exam, okay? But for people that want more support than that, and especially people that want to cover a lot of material in a short amount of time, we do have a 2-day MSRA crammer course, which runs before round 1. For those sitting in September, we won't run it live, but we've got the recording available for instant access. There's over 14 hours of videos. We have a full day, 7 hours on the clinical paper, where we'll cover current guidelines for lots of key topics. We'll do a full clinical mock in equal proportions. We'll cover exam technique and the keywords and how to apply them. And day 2, 7+ hours on the SJT, including all of the GMC and ethical guidance, all of these topics that we talked about and how to apply them, lots of examples of high challenge questions and how to approach them. We've had excellent feedback. We have a lot of people who first time they approached it, maybe didn't get the score they want, didn't get shortlisted for some of the competitive specialties. We had someone this last round. Last year, they got a really good score, 500 and something, but it wasn't enough for them to get a job in anesthetics. This year, they got 625 after coming to the course and, managed to get their first choice job in anesthetics, okay? It's been running for 14+ years. All of the questions in the crammer course are unique to that. So as I said, the recording is available for instant access. Anna will post the links. For those of you sitting, I'll just show you on our website, in January. So if you look here, MSRA, GP specialty, it's the top option, okay? So it's a bundle, the 2-day course, and you get access to the questions until the end of January because they haven't announced a date. It means whenever the dates are in January, you'll still have access to all of the online questions. So the live dates is 2 days, 3rd and 4th of December, over 14 hours of teaching, okay? and then you get access to all of the questions. If you're sitting in September and you want access now, just click here, subscribe now, and you can get access straight away to the recording of the course, okay? And, we help lots of people get the top band and get really high scores and get in, all right? So let's look at common reasons for failure, how to avoid them, useful tips for preparation, and then I'll take questions, and we better wrap up. I think we've got about 10 minutes and we'll be finished. So I'd say the number one reason that people fail is not allowing enough time. And sometimes, it's that people didn't know that they had to sit an exam until after they'd applied because they hadn't maybe read up about the process in advance, or they decided quite late to apply for a specialty that uses the MSRA. Or sometimes it's just that, people are really busy. They're in a busy job. They've got busy life outside of work, maybe young family. Like me, I've got 3 young kids. So, you just don't have enough time, and they underestimate how big the curriculum is. As I mentioned, it's not that each individual clinical question is really, really hard. It's just that a lot of you might not have read ophthalmology for years because you've been doing a different specialty for a long time. You might not have done psychiatry since medical school. Do you see what I mean? So don't underestimate that it takes time to cover these things, and that if you're not familiar with GMC and ethical guidance, learning how to apply that, understanding the SJT, that's a lot more technique than knowledge, the SJT, okay? That can really help. And then focusing on just one paper. So I see lots of people that get a great score in the clinical, but get a poor score in the SJT. Some specialties like GP, psychiatry, if you get a band 1, that's the lowest band in one paper, even if you get 100% in the other paper, it's considered a fail and you cannot be made an offer, even though your total score can be very respectable. And lastly, poor exam technique. People that have put the hours in, have got good knowledge, but miss important keywords, don't understand how the SJT is marked, or the difference between section 1 and section 2 and how to sort of apply it, okay? So how can you prepare effectively? We already covered this earlier, right? That active learning is better than passive learning for long-term retention. But passive learning, reading, has its place. You want to allow enough time to systematically cover the whole clinical curriculum, make sure you've learned and understood how to apply the GMC ethical guidance. You want to practice realistic questions. And that's one of the feedback that we get from a lot of people that use multiple banks, that ours are the closest in terms of layout. Like the SJT, we designed our own software to make sure that it marks the same way and has the same field that you're actually dragging, for example, section 1, to the real exam. Work on your exam technique, do some timed mock exams so you get used to that time pressure. And some people find it helpful to find a study group, to have someone let's do cardiovascular questions today. You do section 1 on the medical questions. I'm going to do them as well. Any that we find particularly difficult, let's discuss it. Let's jump on a Zoom call or WhatsApp and talk about it. Okay, people sometimes find that helpful, especially for the SJT actually, because that can be quite challenging. We do have an MSRA support group. Again, Anna will post a link to that. Feel free to join there. You might find study partners there. And just a reminder, we've got over 2,100 questions on our question bank for S2. If you haven't already started and you're sitting in September, please use this as a springboard. Well done on attending today and giving up part of evening. Hopefully it's kick-started and given you an idea. Remember, it's not just simple pass-fail. You can pass and get no interview. You can pass and get no job. You're competing against lots of other people, and the level of competition has increased hugely in the last 2 or 3 years. You might have read about that, okay? So, just make a start now. If you're not already doing questions, start doing questions from tomorrow. We've spent an hour doing questions today, but from tomorrow, be doing questions, be doing your reading, and you're going to get there. Okay. So I'll leave you with that, and just leave you with some of the sort of feedback from people that have done really well in there. But what we'll do is we'll take questions now. Someone said, is a non-training job for 6 months a disadvantage? No, as long as you're going to have 2 years clinical experience, including internship by the start date of training, you meet the experience requirement. And then remember, for all specialties except for GP, you need your certificate of, foundation competency. So either if you're in foundation, you just need to name your foundation school and you submit your foundation certificate later. If you're not in foundation or haven't already got a foundation certificate, you need the CREST. For every other specialty apart from GP, you need it on the day you apply. For GP, you can submit later. There's an extended deadline. So the 7th of October for round 2, okay? Someone said, does portfolio matter to apply for GP training? No, there's no requirement and no place where anyone's going to look at. There's no interview at the moment. It's 100% based on your MSRI score. Just some more examples of people that found the course really helpful to get into radiology, anesthetics, psychiatry, ophthalmology. They got their top, this is an international graduate, got their top choice in London for ophthalmology. Ophthalmology is already competitive. London is the most competitive program, and they got that. Okay. And just a reminder, we've got the case cards there. So anyway, Any other questions, please ask in the Q&A and I'll pick those up. For anyone that hasn't got questions, let me just summarize so that you can get away. Just before we go, do join the MSRA support group. If you're applying for GP training, we have a dedicated group for GP training, which covers a lot more because there's a lot more people in. It's the biggest group in the world dedicated to GP training. It's 27,500 doctors in there. And then do subscribe to our YouTube channel because I often post little clips, tips about MSRA, about clinical topics, about different things. So, you'll get notified when they pop up. Anna will post a link again. She posted it earlier. But just to summarize, look, this is a two-part assessment. By the way, the clinical paper and the SJT paper are equally weighted. They both count half-half, okay? Whether you get shortlisted or not for those specialties that include interviews as part of the process is going to be based on how well you do in MSRA. And then it carries over. And then for things like GP and psychiatry at the moment, 100% of your rank is based on MSRA. Remember, it's not simple pass-fail, it's competitive rank. Every mark matters. Sometimes one mark could be the difference between getting a job and not getting a job, or getting your first choice job and your second choice job, which might be further away from where you want it to be. So, and because it's so much more competitive, to give you an idea, in round one for GP, 6,500 and something doctors passed and were ranked for 4,200 jobs. There were about over 7,500 that applied. So, some failed, they didn't even get a rank, but 6,500 were ranked, only 4,200 jobs. Do you see? So just passing doesn't mean you're going to get a job. Things like radiology, you sometimes getting 4 or 5 applicants per job, and they only interview the top so many, okay? The top 600-700 or whatever, okay? So you want to get the best score possible. So focus on your revision. Do something every day. Be consistent. Practice under time conditions, and then you're going to get there. And I leave you with this, 2 bits of important reminders. The first from Michael Corder: to succeed, we must first believe that we can. Whatever specialty you want to do, if you decide, oh, that's really competitive, and so there's no point trying, you know what? If you've already decided that, you're right, there's no point trying, because if you've decided you're not good enough, then you're not good enough. Don't bother wasting your time. But instead, if you have the attitude that someone has got that job, I could be one of those, and you're willing to work for it, and you have a positive attitude, then you're probably going to put the hours that need, because it's competitive. You've got to sacrifice some hours. You've got to sacrifice. We'd all like to be watching movies and chilling and doing other things after a busy shift, but sometimes you've got to then do some reading or practice or read a few more case cards or do a few more questions or do another mock. But those sacrifices means you get the specialty that you want, okay? So to succeed, you must first believe that we can. And then you've got to work for it. From Malcolm Shabazz, the future belongs to those who prepare for it today. You've taken a big first step. Hopefully you've got a much clearer idea about the exam. You understand the difference between the different sections of the SJT. You understand the curriculum and what's being assessed in the MSRA, and got an idea of some of the medium and challenging questions. We didn't do many that are very straightforward. In the exam, there'll be some that are easy too, right? Okay. But now you understand that. If you first think, you know what, I could do this, and I'm willing to put the hours and work in, and then you put the hours and work in, come the results, I get an email from you just to let you know I got my first choice job in my first choice specialty. And as I said, that can happen no matter which specialty you want. We've helped people get into every single one of those specialties pretty much that uses MSRA. So, you can do it. You've just got to work for it. Whereas if you give up before you even started, you've got a mindset of failure. You're going to fail. You set yourself up to fail. Okay. So for anyone that hasn't got any other questions, all the best, whether you use our resources or not. I hope you found today helpful. Hope it's given you a clear idea. Keep pushing, keep going, prepare, and you will succeed. Thank you so much. Have a great evening.